My name's Ren Sommers. I'm at the Mayo Clinic in Rochester, and I'm a cardiologist with a strong interest in sleep and cardiovascular risk. And this is a follow-up to a symposium that we had in Boston some time ago on narcolepsy and cardiovascular risk. And I was joined by two very excellent colleagues, Dr. Richard Bogan and Dr. Phyllis Z. And we're going to just very briefly recap some of the key points and some additional questions that we hadn't addressed in the original symposium. So I'm joined today by Richard. And Richard, do you want to introduce yourself very quickly again?
Sure. Yeah, I'm Richard Bogan. I'm pulmonary critical care trained, sleep medicine, now in Columbia, South Carolina, and I'm affiliated with the Medical University of South Carolina in Charleston and the University of South Carolina School of Medicine in Columbia, South Carolina.
So, Richard, getting back to the issue of narcolepsy and cardiovascular risk, I want to touch briefly on what as someone who sees sleep disorder patients yourself, and as someone who is skilled in treating sleep disorders as well. How do you diagnose a narcolepsy patient? What makes you think of narcolepsy when you see the patient, and how do you approach them?
Yeah, we talked about this some, but the problem is these individuals are sleepy, as you well know, and but they also have REM dissociative symptoms, and by that, what I mean is the basic defect is the brain is okay, but the control processes that help the brain stay awake and have an adequate degree of alertness, therefore the lack of sleepiness doesn't work properly, and that seems to disinhibit the sleep and the REM generator. So these individuals are interesting because you or I, we're awake in the day and sleep at night, but because of this neuropeptide called orexin is not working properly, at least we know that in type 1, type 2, we're not quite so sure, but they sort of oscillate between wake and sleep, but they do it at night as well. And at night, they'll tell you most of them have vivid dreams, and they may wake up and feel as if they can't move briefly, sleep paralysis, or the dream may continue even when they wake up. So they may hear something or see something that's part of the dream. It's momentary. But when we see symptoms of sleepiness, despite an adequate opportunity to sleep, and these REM dissociative symptoms, then that is suggestive of narcolepsy. Now, our fellow physicians and healthcare givers, we have to give them credit because 30% of the adult population is sleepy. And so there are a whole lot of sleepy people, and narcolepsy is only about 1 in 2,000. So you have to be suspect. These individuals are very sleepy, and so they will complain of fatigue or cognitive abnormalities or mood changes, or they may even present to you with poorly controlled hypertension and cataplexy, which might sound like a syncopal episode, but it's really loss of muscle tone. So they may present to different clinicians, psychiatrists for attention deficit problems or mood changes, or their primary care for fatigue, but they're sleepy. And if we quantify that degree of sleepiness, then we'll begin to recognize that there's an abnormality.
So if I see somebody with a diagnosis of spells, apart from aortic stenosis and arrhythmias, I should actually also think about narcolepsy with cataplexy.
I think so. These individuals have sudden onset of muscle weakness associated with strong emotion, laughter, or a negative. So they could be mistaken for seizures or fainting or cardiovascular problems as well. And the difference is they're still awake. They lose muscle tone and they can hear the environment. So it's very different from fainting, but oftentimes they come to us through either psychiatry or through cardiology with the episodes of syncope.
So the key issue here is they do not lose consciousness.
Right.
And so we need to be careful not to think that this is a psychogenic episode.
Correct.
The patient may be pretending to be falling because they don't lose consciousness and dismiss it as psychosomatic. It could be narcolepsy.
Yeah, exactly. I had a patient one time who presented to me. Her brother used to love to surprise her and she would collapse, and he thought that was the funniest thing in the world. And this is a teenager who was getting ready to go to college, and so she saw the cardiologist for syncope. They did the tilt table test and all that for orthostatic changes. She saw the neurologist for seizures, and then ended up seeing a psychiatrist for conversion reaction. She had cataplexy, and with appropriate treatment, she did fine.
So it's an uncommon disease with a unusual presentation, and it could be a presentation to a general physician, a psychologist, a psychiatrist, a cardiologist, or even a neurologist.
Correct. Absolutely.
And so we need to be aware of that.
Yeah.
From a cardiology point of view, we also have to look for things like high blood pressure. Narcoleptics are at high risk for high blood pressure, and they tend to be at risk to develop obesity or being overweight. And so that's something we need to be aware of. For the hypertension specialist, someone who's non-dipping at night needs to be considered as a potential narcolepsy patient if they have the relevant symptoms. Now, I'm going to ask you a little off-the-track question. What do you foresee as the potential role for administering exogenous orexins in patients with narcolepsy?
Yeah, I've heard you speak about orexin and its effect. Orexin is a neuropeptide that is actually located in the hypothalamus. This is a primitive circuit. It's not a lot of neurons, only about 100,000 neurons. But when our clock turns on in the morning, it activates those orexin neurons, and that branches out and keeps us awake. But it also affects hypothalamic pituitary axis. It affects sympathetic tone. We breathe more when we're awake. Our blood pressure and heart rate go up. We're ready to be awake and feed ourselves and protect ourselves when we're awake. So orexin is a very important neuropeptide. And as you know, in type 1, they don't make orexin. So there are all these potential downstream effects, including, hypertension, immune modulation, and cardiovascular and CNS problems that narcolepsy patients might have. So the orexin is kind of the holy grail. If they don't make enough, type 1 patients don't make orexin. If you tap their spinal fluid, they don't make it. So orexin is a very important neuropeptide. Now, we don't have that, and we do have other treatments, but those other treatments, are activating and stimulating the neurons, and so they do have an effect on the sympathetic nervous system. So we worry about, tremor, anxiety, CNS effects, cardiovascular effects on the blood pressure and heart rate because we use Schedule II drugs or other stimulants. So we have a lot of concerns about when we treat our patients to make sure we're monitoring their weight and also monitoring their cardiovascular status. It's very important.
I'm taking away from all that orexins have pleomorphic effects, and so they do have an impact on a number of different regulatory systems. One of them is
including feeding.
And that's exactly what I was going to say, feeding. And so this is why narcoleptics tend to be more inclined to be overweight or obese. And whether the abnormal sleep patterns are further contributing to their appetite dysregulation, we don't know. What we do know is if we take healthy young people and sleep deprive them, they will eat more.
Yep.
And how that applies to narcoleptics in conjunction with orexins is an interesting question.
Yeah, I think it's very interesting. Yeah.
Your point about the diffuse effects of orexins also then relates to the multiple comorbidities of narcoleptic patients. So really any specialty or any general physician who's seeing somebody with a disease like diabetes or hypertension or obesity, and that patient has some unusual symptoms that could potentially be narcolepsy with or without cataplexy, we need to think of narcolepsy.
Yeah,
and maybe
I would challenge. Yeah, I'm sorry. I would challenge the clinicians if they did a score that would quantify sleepiness, the Epworth score, 8 questions, takes 30 seconds to do it, patient self-administered. If you have a patient with fatigue or attention problems, executive function abnormalities, or mood changes, anxiety, or any of those, if you do Epworth score on all those people, Do it just for 2 weeks. You'd be amazed at how many sleepy people you find. And of course, narcolepsy patients, their Epworth score is up around 16, 17, 18 out of 24. My Epworth is 6. I'm a night owl and I stay up too late. So but I'm still a 6. So I'm 10 or below. But I would challenge the clinicians to do the Epworth score on every patient for 2 weeks. You'd be amazed how many sleepy people you find. But to your point, if you have a patient who's impaired, tired, something's going on, then do the Epworth. If there's a brain symptom, do the Epworth.
Something worth remembering is that there's emerging data linking sleepiness to an increased overall cardiovascular risk. Yeah. Certainly in apneic patients, the sleepiness is a sign of potential heightened risk. And then that brings me to the next question, which is, tell us about the comorbidity of narcolepsy with something we see much more frequently, namely sleep apnea.
Sure. Yeah. For some reason, there is a higher prevalence. Now, part of that may be obesity. Part of it may be that state instability issue that we talked about. Could be orexin. Who knows? But certainly there is a higher prevalence of obstructive sleep apnea. And of course, if you have obstructive sleep apnea, when you're asleep, that upper airway is collapsing. You're not getting enough oxygen. Your sleep is even more fragmented. And of course, every time you wake up, you get an increase in sympathetic tone. So this and the oxidative stress, both of those are not particularly good for the heart or the blood vessels or the brain. So we can certainly see obstructive apnea as a confounder in these individuals. And it's probably north of 25% of patients with narcolepsy will go on to develop obstructive sleep apnea later in their lives. So we have to be aware of that as well.
Great. Now, as someone who treats cardiovascular disease and sleep, you specifically, what are your thoughts about the current treatment options available for narcolepsy in relation to cardiovascular outcomes?
Sure. So I alluded to that earlier. Obviously, we use Schedule II drugs. We're worried about those because of tolerance and the sympathetic effect. So talking about methylphenidate and amphetamines, I mean, they clearly have an effect on heart rate and blood pressure and the brain, but that doesn't mean we shouldn't use them, but we worry because of these comorbidities of hypertension and cardiovascular disease to monitor that. We have wakefulness promoting medications as well, and those can affect heart rate and blood pressure. So the modafinil, armodafinil, and solriamfetol can. Now we have a histamine drug, pitolisant, that doesn't seem to have as much sympathetic effect, but it does have an effect on the QT interval. So it can prolong the QT interval. So every time we use a medicine, we have to, keep in mind that it might have an effect on the heart or the brain that might be adverse. Of course, one of the medicines that we use now that's approved to treat cataplexy, as well as the sleepiness, is we have pitolisant, the histamine drug, but we also have oxybate. And sodium oxybate was the only drug approved at one point for cataplexy, and it has a huge effect. I mean, it's a very dramatic effect in terms of stabilizing states. So the patients tell us the REM dissociative symptoms improve, the quality of the sleep improves, and then when it wears off, they wake up, and their cataplexy seems to be a lot better, and the sleepiness when they respond. Now, not everyone responds, but we use sodium oxybate. But the problem with the sodium oxybate was the doses that we used was a lot of sodium. It was up to over 1.6 grams of sodium in some of our patients. And as you well know, that's a lot of sodium. Now, when we decide to use an oxybate molecule, rather than using the higher sodium content, almost all of us have moved to the lower sodium oxybate preparation. As I said, 92% less sodium, same active moiety of oxybate, which is metabolized to GHB, and this particular molecule, when it's tolerated and works, it dramatically improves both states, sleep, wake, and cataplexy, and has lower sodium.
To emphasize the point, is these patients at high risk for hypertension, and then when we throw in the sodium on top of that, with the possibility of sleep deprivation, with the possibility of obesity, with the possibility of salt sensitivity, then we're really asking for trouble in terms of blood pressure levels, and eventually, possibly, in terms of heart failure risk.
And I mean, we're using other drugs that increase sympathetic tone as
Yes.
well. So
Yeah.
I mean, that's and you. I mean, I would throw it back to you. I mean, if you tell a patient to drop their sodium load by 1.5 grams, I mean, you anticipate that's going to improve cardiovascular health, I would guess.
Yeah, it's a first step in many treatments, treatment of hypertension, treatment of heart failure. So it is an important consideration. So thanks, Richard. It's been great talking with you again, and I'm hoping we can revisit the specifics of our symposium sometime in the next year or so and address some new developments.
Well, I appreciate the invitation. It's nice talking with you.
You too. Take care. And thank you all for listening again to this discussion.